So good morning, colleagues, and welcome to this morning's session. Oh my goodness, technology is not with me this morning. Welcome to this morning's session, which is a session on innovations in community-based care. We are excited to see so many of you. My name is Kira Fortune. I'm the Regional Advisor of Healthy Cities, Wellbeing and Health Promotion at the WHO office, which is the regional office of the WHO in Copenhagen. And I have the grand pleasure of chairing this morning's session. We are very fortunate to have 8 wonderful speakers with us. We are going to have 6 interventions, but some of our panelists will be co-presenting. And we have decided as a group that we are going to go through all 6 presentations, and then we will take questions at the end. So I'm sure there's going to be a lot of questions, but please hold those for the end of the session. I also want to remind you that this session is, of course, recorded and will be live streamed, and you also have the opportunity to, again, put your questions through the app, and I will, of course, be keeping a beady eye on those. But without further ado, colleagues, I would like to present to you our first presenter, and that is Tatiana Dnestrean. She is from the Healthy Life Project, and she will speak to the integrated community care models in Moldova. The floor is yours.
Thank you. My name is Tatiana Dnestrean. I'm here from Moldova, representing the Healthy Life Project that is trying to reduce the burden of NCDs. We are, let's say, a small project, but implemented based on the agreement between Swiss Development Agency and the government of Moldova. And within our experience, we are trying to put together, first of all, to improve and strengthen the structure and policy health for public health, especially local structure and multidisciplinarity in the decision-making. The second is we are trying to improve the quality of primary health care, especially early identification of risk factors, screening, and prevention, as well as follow-up of people that already have some signs of health problems, as well as self-management program that is trying to improve the quality of life of those that have need of support. And the third objective is to integrate at the horizontal community level all the structures that can help, first of all, to prevent, second, to improve the monitoring of the NCDs, and third, to ensure long-term care and palliative or home care-based services for those who have complex needs and especially have more or let's say, are in poverty or have no relatives or families that can look after them. As a concept, the horizontal integration would look like that. In the middle, we put people, person, individuals that have a specific needs. The base or core team is represented by the community nurse that is in place in Moldova from 2014. Okay, we have some problems. We need more education in place. We need more clear vision of the community nurse. But we are working on this. We're still working. We're still to promote the community nursing. And the community social worker that is in place since 2007 in Moldova and has this prevention and the facilitation of entrance within the social system. Somehow we have 2 positions or 2 professionals that are representing entry point into health and social system. For us, it's important to put these people together to work on case management and to classify people according to their needs because it is more simpler to let's say, manage the long list of people waiting for services, as well as it is helping to intervene at the early stages. We put a big, let's say, expectancy, or we hope to have support from the formal and informal carers as people who can take from the shoulders of professionals some elementary or primary support, as well as we try to attract other sectors, something like education, police, that have also some resources that can be used, as well as NGOs, civil society, that are not very coordinated, not very unified, and we are trying to attract them and to target the resources that are available in this sense. At the community level, we see the coordination and leading role in the public authority, but we follow the existing referral system. Actually, we are not creating new services, and we are not innovative. We are not inventing new structures. We try to improve existing resources. We try to improve coordination. They are working procedures. They are working tools in order to communicate as much as possible, to exchange information as much as possible, and react coordinated and simultaneous. Something like try to put together very small resources that we have in public system. We are trying to improve the public system because it's more sustainable. Yes, we are project-based intervention, but all activities we do, we are trying to institutionalize them, starting from the curricula, training modules, structures, as well as equipment that is allocated to existing structures, something like primary health care or local public authority, who sign that all this will be used for the most vulnerable. At the district level, let's say in your case would be regional level, we see the public health structure as a monitoring leading team, because we have at the district level such councils like territorial public health councils that already in their platform have multidisciplinary team. All decision makers from the old structure, they decide on the strategies, on the actions that could, or solutions that could be used. We think that this structure should also monitor and evaluate integrated care at the community level, because what we want to do, we try to prevent hospitalization and acute services and intervention. What is happening now in Moldova? We are trying to face consequences of multiple crises, starting with COVID that we didn't recover yet because, you know, people, especially people with NCD, were isolated. We tried to improve adherence to the treatment, to be there with those isolated, marginalized elderly, without families, without support. Already the war from Ukraine, that was not just like a safety crisis, but also Moldova received, let's say, not unexpected, but maybe it's the first experience of Moldova receiving so many people, and trying to help them. As you'll see later, most of them are in the communities, and they will use the public services, NGOs, and international support. But the, let's say, challenge was to identify those who need support and to provide them in the right time and the right place. And already energetic crisis that affected even the good or poor, or let's say not poor, but well-being countries, but in our case, the most affected was people vulnerable in rural communities that already were in the poverty, but now we have refugees with us. I will take the specific case of refugees because, I don't know, we already know about COVID, is what it was, let's say, assessed and discussed most of the time. Maybe nothing new would be added to that. But when speaking about refugees, I can say that we, as a country, we try to respond to the needs and to the situation that came immediately. The most difficult was because you'll see around 100,000 of people, they go through Moldova. This means that people that are come need quick support, emergency support, and go out. And you'll see under 100 remain in the country and they needed support. Most of them are women with children, and we will have a proportion of 20% of elderly people. Somewhere 97% of them were absorbed by communities. And if you look through the first graphic, somewhere 56% were quite well. They succeeded to rent a flat and to cover necessary expenditure. The next 20% were, let's say, using the relatives. But, you know, here you have emergency and even this psycho-emotional support. For our interest, it was there, the last small, something like people that were hosted in the random families that were offered themselves, and people that needed more complex support that were placed in temporary placement centers. First months were more, let's say, difficult because it was a situation when the community should mobilize their resources. We had no, as a poor country, we have no resources in advance to spend. And everything is counted on people, on service, you know, when you're struggling for finance in the system, especially in the health and social, as the most, let's say, exposed. But here what happened is local public authorities tried to cut some expenditure from existing services and mobilize them to use for refugees. I can give an example, for example, the education sector. They cut the resources that were needed to feeding children and targeted them for the packages for refugees. It was something like rethinking and being very creative at the local level. Another resource was public donation. We were surprised to see that people were sharing from their small resources. And this was probably most emotional thing because the communities mobilized between them and tried to organize first emergency, starting from the elementary needs and covering after the sleeping. And also it was done something like a research of the needs, or not research, but assessment of the needs, quick assessment of the needs. Most of them needed money to survive. In kind like material support, and around 30% would need health services as an emergency, as an immediate. After that, in 2-3 months, already international organization came on board with good resources, and you'll see the next. The refugees were provided with monthly support in cash to cover the basic needs, and after that, additional support was provided for the families that hosted or received refugees to cover this expenditure, because even if you have your relatives with you, 2-3 days it's okay, but when it goes more than 3 months, it has already become problematic. Especially this was a combination with energetic crisis. Prices increased, and we should cover all this expenditure. Temporary placement centers, but these are not new. They are covered all the needs. Something like this were the most vulnerable people, but they had this safety network because the center usually cover all the needs of the people. Again, this is mostly of them women with children, and you'll see in the corner most of our pilot communities, they had such kind of service. We could even share our resources between temporary placement and community-based, because if they were not spending or not absorbing all the humanitarian aid provided by, again, a lot of humanitarian aid provided by international organization, that sometimes it was a feeling that too much, or they are not raising the right people. And the role of community team was to identify these right people to receive support. Health services was provided, or health support was provided based on the ministerial disposition that ensured the access to primary health care. And you'll see in numbers, but in the medium, a family doctor would receive 10-15 consultations per day. About our adjustment, it was necessary to give additional competencies that are referring to refugees. This is trauma, this is immediate support, and sometimes professionals tend to confuse philanthropy with professional intervention. We put accent on that we should build resilience of refugees to take care of themselves. Because the tendency was to put them in a temporary placement center and to take care of them like babies. It's not the right approach. What we did, we also provided a guide for community social workers and community teams to make this difference between taking care and support people to be more resilient to what's happening to them. And also, because we are very, let's say, we have limited resources, we tried to compensate lack of equipment. The tendency, the capacity of community teams improved, and you'll see because of this, let's say, need approach and integrated care assessment, it was possible to classify interventions according to the support and to do these structured interventions. What we learned is that integration is helping us to managing very limited resources. That due to coordination of efforts, we can get to those most vulnerable, and because we are a project-based, all we do is a project-based and piloting-based. We need regulations and legal framework because we will need to change job description to allocate more resources for those who are, let's say, on those shoulders are communities. We need to support community nurses and social workers. Thank you very much.
Thank you very much, Tatiana, for a wonderful presentation and for so generously sharing your knowledge with us. You said at the beginning when we first met that this is a young program. I think you should give yourself kudos. It's very impressive, the work that you have done. And I'm sure there will be a lot of questions. If you could hold those for now, colleagues, and we will take those questions at the end. Colleagues, we have just been to Moldova. We are now going to take you back here to Belgium, and I'm very pleased to introduce our next two speakers. I'd like to introduce you to Rose Vzw from the International Foundation of Integrated Care and Tinne Vandensande from the Baudouin Foundation. And Rose and Tinne, they will be co-presenting their learning and experiences of the Transform community. The floor is yours.
Good morning, everyone. It's a real honor, pleasure to be here. I'm Rose Vzw, and this is Tinne Vandensande, and we'll be walking you through the Transform journey, so integrated community care, and how to turn it from aspiration to reality, and hopefully the new way of caring for each other.
Good morning, everyone. Thank you for joining these presentations on community care. Before we are diving into integrated community care, I think it's good to remind the broader context. It's a broader context, as you know, of multiple crises, multiple transitions, with increasing inequalities as a cross-cutting issue. The key message with this slide is that the current health and care system is no longer fit for purpose. It was designed in and for a different time, with both diseases and problems that were completely different. What all the current challenges we face have in common is that they are interlinked and that they require collaboration and participation. So they require us to redefine and redesign care for the world of today and the world of tomorrow. And care is there the key word. We need to think about a much broader definition of care that goes beyond the traditional meaning of care, of hands-on care, caring with. We should move to caring about and caring with. New concepts of care are tested, like goal-oriented care, at the beginning of the conference. And existing concepts of care are broadened, like primary care. So we don't know yet where we will land, but the ongoing movement has at least common features. And integrated community care embraces this complexity and welcomes all these new perspectives of care. We are moving, if we think about the different conferences on integrated care, we are moving from patient-centered towards person-centered, and we are moving now to people-driven care. That brings us to the Transform Partnership and the start of integrated community care in 2018. The concept of ICC, which is the abbreviation of integrated community care, the concept was launched by the Transform Partners, a partnership of philanthropic organizations from across Europe and Canada that has become an international learning coalition aiming to foster integrated community care for all. The community is the place, the community is the partner, and the goal of ICC. And this learning journey has been driven by a wide range of change makers for ICC present at Transform conferences, workshops, Go and See programs, and investing in locally anchored innovation and making a real difference in the daily life of people. Together with citizens, patients, experts by experience, academic experts, practitioners, professionals, and policymakers, we identified key values, the key ingredients of ICC. So what is ICC? How do you realize ICC, and why do we need integrated community care that we have brought together in a very comprehensive definition, what we call as a root definition. So ICC encompasses a range of strategies to support local organizations, community members, professionals, and policymakers in a continuous process of co-developing health, care, social support infrastructure and services with the aim to enhance the quality of life, social cohesion, and the resilience of a territorially defined community. That is our comprehensive definition. Sounds very theoretical. Let's go to practice.
Thank you, Tinne. So based on the experiences of this Transform journey, and particularly from the Transform change makers that you can see up on the screen, there's the ones up on the screen are from the Change Makers Forum, but I really want to say that there's about 30 more innovative practices that throughout the journey we showcased in the various conferences. And so I guess our learnings and our understanding of what integrated community care is and can be is based on those, but also 30 more. So in the next slides, I will describe what ICC is, not only conceptually, but also with some real-life examples, hopefully, so you can get a flavor of what it really looks like in real life. Thank you. So what is integrated community care? ICC for short. So ICC acknowledges that communities are essential partners. ICC envisions a paradigm shift in the way health and care systems are organized, from delivery to genuine co-development. So if integrated community care is really about changing the way that we conceptualize care, from caring for someone, for caring for people, to really caring with and about. It's about recognizing communities, but at the wider level, and people, individual citizens, people with lived experience, crucially as equal partners. So it's about that co-production and about moving from people-centered to people-driven care. So all the best examples that we have seen of ICC are rooted in communities. They tend to be bottom-up initiatives with top-down support. They're what we know as asset-based, so they take the community's strengths and resources as a start point. And a nice example is Kwaito, which is in Flanders here in Belgium. It's one of the Transform Change Makers. It's a cooperative association of 10 organizations across the region that have expertise in long-term and intensive care, and that they're pioneering these new ways of caring. They call it the social embedding of care. So they promote care within social, economic, and environmental sustainability projects, and through innovative housing, daycare, work, leisure, and mobility models. What does that actually, look like in practice? You probably will recognize this, but in several rural villages in Flanders, like in many other places in Europe, there's a problem of depopulation. So that's a loss of both public and private services. So these villages a lot of villages end up being like ghost towns, if you will, and the people that live there end up isolated. So what Kwaito did was to help breathe life back into these communities by co-designing, co-developing neighborhood points. And they all look different, but they were all developed by the community. So it's about the start point, it's about bringing everyone together and listening. What do they want? What do they need? And how can you get there together? So a lot of these neighborhood points, I wish you could go visit them. They're really beautiful, very cool places. But they're vibrant places that host everything from community libraries. A lot of places didn't have these anymore. Shops in partnership with local producers to try and promote the local economy and produce as well. Cafes, mobile bakeries for people who missed having their croissant and suddenly there was no bakery. They make it happen, whatever it is that they want. Play areas, activities for local children, meeting areas that can be hired out for any activities that they come up with themselves and that they want. And people with disabilities are employed there, so they're known as employees. So despite they've only been around for about 5 years, and you will have probably heard and seen that anything integrated care related or integrated community care related takes time. It's not something that you go like, right, let's do this for 2 years and see what the benefits are. It's not how it works. But despite only being around for 5 years, it's already created innumerable connections between the communities, and it's a different way of thinking of care, essentially. The philosophy and the intention is for these to be owned by the community, and so the coordinators that help facilitate this are just that. They're facilitators, and they're there to connect people together, but it's a very important role, again, in ICC. So co-development as a key part of ICC is important from the individual level with things like goal-oriented care that you've all been hearing lots about. But it's also important in the wider sense with the community, and that's a key part of ICC. Next, please. Sorry, my throat gets very dry in presentations. ICC emphatically addresses the broader determinants of health. It focuses on both the quality of care, but also the quality of life and the broader definition of care. It pivots on integrating between primary care, also public health functions, social work, and neighborhood development within the given territory. So we've been talking a lot about the social determinants of health in this conference, and there's a crucial difference between asking people to help themselves and self-manage and send them a social prescription. But people aren't always able to self-care or act on the advice that they're given because they have no control over, often they don't have control over the wider socioeconomic and structural problems that they face. So a doctor might encourage someone to do more physical activity or to eat a healthier diet, but the person may not have time to prepare healthy meals or access to suitable space or motivation to exercise. So transformed change makers, all that you saw earlier, are all acutely aware of the people's context and proactively seek to improve their overall life conditions as a crucial part of care still. So for example, Ikambere that you see on the screen is an organization in Paris, and they support women in vulnerable situations with long-term conditions, say HIV, diabetes, obesity, hypertension, not only through helping them manage their medical side of things, their physical health, but they address their broader socioeconomic needs. So they have a multidisciplinary team of social worker, they have therapeutic education officers, they've got health mediators, but they also have professional integration officers to help them figure out how to get back into the workforce. A lot of them are migrant women. They have a dietitian, a fitness coach, and they accompany the women to be able to live the life that they want to live and be a part of society. So this way of working is a different way of thinking about caring. In terms of integrating primary care, public health functions, social work, and neighborhood development, a nice example is Polyclinic Vedel. They're a community health center in Hamburg, and they have a strong focus on social justice and the social determinants of health. They politicize health in Hamburg. They want to make it for all and not for a few, like unfortunately it still is despite the system. They actively try and reach out to the communities that they work with, and they support locals in organizing themselves in groups to articulate and advocate for their needs. So an example is they identify joint solutions for struggles that were previously perceived as not my problem. As a carer, as a part of the care system, it's not my issue. That's your problem. If you don't have appropriate housing, if you're going to be evicted, unfortunately, I don't have time for this. It's not my realm. So the Polyclinic Vedel does recognize that this is part of care. They have a community worker that supported a group of about 100 tenants that were being evicted from the social housing building. They found support from a lawyer. They held meetings with politicians. They involved the local press and building owners to guarantee that the building would be renovated and inhabitants wouldn't be evicted. They were successful, and it's little things like this, but by politicizing and making it visible, they're trying to change the system. Oh, sorry, could you go back a second?
Okay.
Thank you. Calico is another example about the quality of care and quality of life side of things. So that's a nice introduction to the next one. So again, ICC is about place-based governance and continuously forming new alliances, not only health and social, but as wide as you can go. What's in the community? Who do you need to ally with? It comes down to a continuous process of whole of system innovation, and it's about distributing power and collective learning. So Calico began as a shared vision of several like-minded citizens and associations in Brussels. They wanted to come together to build a healthier form of living and, again, of caring for each other. They really were acknowledging that there's all these other aspects in our life that affect our health and well-being, and how do you incorporate that with the actual physical and medical the more traditional side of things. They've got a wide partnership of 8 associations, which includes everything from healthcare institutions. So they've got the university hospital providing support for example, the birthing and dying homes, and you can read about it more later in the report that we will share with you, because it's very interesting, and I have never heard of anything like this, co-located care services in people's homes, essentially, that is co-designed and co-delivered with the residents. Anyway, the part going back to the governance and the partnerships, you've got the healthcare institutions, you've got policymakers, you've got social enterprises. The project was recognized as an urban innovative action. It was funded by the European Union Regional Development Fund initially, and its governance arrangements, you can see, are complex and they're still evolving. But I think a crucial part of it is that the residents in Calico are involved in the governance. They're the ones that say what they want, how they want to be cared for, and how they want to care for each other. So the governance committee has the residents there, but also they've got a care committee for the community care side of things, including the birthing and the dying houses and the neighborhood outreach. With redistributing power and collective learning, this is a huge part of ICC. It's really about not seeing them versus us, or seeing, oh, the third sector, we should really speak to them, or the volunteers, we should really figure out how to reach them. It's not, oh gosh, no. It's really about, we're all in this together, and so we're equal partners. You've got caring communities in Montreal that pioneered the model, the peer partner model, where peers with significant lived experience of everything from chronic diseases to homelessness to migration to everything. And you've got, again, an example is when you are doing research, when you're involving people from the community themselves or people with lived experience themselves to be part of the research, not to ask them, how did this project go for you, but to really go like, what are the questions that we should really be asking in the first place? What matters to us? Too excited, there's so much.
I need to conclude already, so that's a bit earlier than we thought, but with the practices shown by Nieves, it's clear that ICC is not a prescriptive model, not at all. It's neither a managerial toolbox, but is really a systemic approach. And we tried to find a common language and a strategy for ICC. And we did that by building together 7 effectiveness principles, a framework of 7 guiding principles for ICC that helps innovators on the field. And effectiveness principles comes from the approach of principles-focused evaluation and developmental evaluation, which is a methodology much used in the US and Canada, and it helps us to evaluate differently when it comes to innovation on the field. I will not go into detail. You can read what an effectiveness principle is. It's a really clear, actionable statement that helps you to guide your innovation. 7 principles along 3 sections. Actionable always. You can see that because we always use a verb to start the principles. I will just pick one word per principle to go through them. The first one is on the active involvement of all actors, with an extra sensitivity on the most vulnerable ones. The second one is on investing in broad local alliances and actively strive for balanced power relations and mutual trust. The third one is about community-oriented primary care, starting from goal-oriented care and taking people's life goals as a starting point. Next, we go to the section on building resilient communities, where we really focus and invest on reducing health disparities and invest in prevention and promotion. Fifth one is to support inclusive communities and investing in social care and social infrastructure. Sixth one is, with a long-term perspective, you should develop in the legal and financial conditions to enable real co-creation of care and support at community level. And the last one is on monitoring, evaluating, learning, and adapting. but together with the community. That means it's participatory evaluation, and that means that the professional benchmarks should be secondary to the benchmarks of the community. So that's the framework. It's quite simple, direct framework. Everyone can use it, and I would make a plea to take it home with you and try it out.
Thank you very much, Nives and Tinne, for a fantastic presentation and for really translating that theory into practice. And again, I'm sure there's a lot of questions for you, and we really appreciate your enthusiasm as well. On that note, I would like to invite our next speaker up here, and we're going to stay in Belgium, and I'm very pleased to introduce to you Ann-Marie Morel, who is the founder of A Touch of Rose, which is, again, as I said, based here in Belgium, and Ann-Marie will share her work on an integrated and holistic care approach, drawing upon her work from the Flemish drop-in houses. The floor is yours.
Thank you. Good morning, everyone. Today I would like to tell you the story of 3 drop-in houses in Flanders: Casa Calienta, Coda and A Touch of Rose, of which I am the founder. Since 2000, I have been working at the hospital as a pulmonary oncologist, caring for patients with lung cancer and mesothelioma. I was also part of the palliative team, where I guided patients in their last phase of life up to and including euthanasia. I was very involved with my patients and did everything I could to take care of them as well as possible. By the way, I still do. And then life is what happens to you when you're busy making other plans. In 2009, my younger sister, Marie-Rose, was diagnosed with metastatic cervical cancer at the age of 35. And suddenly I got a different role. I became the sister of a patient with cancer instead of the doctor caring for a patient with cancer. In 2013, my brother of 35 years old also got diagnosed with a malignant pulmonary tumor, and he died 1 month later. During my sister's treatment, it was very obvious to me that professional, emotional, and psychological support could change the way my sister was going to deal with this diagnosis. It was important that she could be an active participant in her treatment and take control of the process where she could. Initially, she got a very intensive treatment with chemotherapy and radiotherapy with a good response. During this period, she got a relaxation massage that was marked as one of the rare days she did not feel as a patient, and that gave her extra energy for the following treatments. 1 year later, she was told that there was a relapse and that she could no longer be cured. At that moment, a second-line therapy was not yet proposed because she had no complaints and the focus of the relapse was unclear. My sister then felt that she had to take matters into her own hands and started her own search for all kinds of complementary therapy. As an oncologist, I could support and advise her, but so many patients do not have this extra support at their side. Finally, she lost her battle and died the 8th of February 2011. But what I experienced during her period of illness laid the foundation for the creation of our psychosocial oncological well-being center we opened 7 months after her death. A Touch of Rose was born. When we look at the cancer diagnosis and prevalence, we see that there are almost 70,000 new cancer diagnoses in Belgium every year. And we have an expected increase with 3% every year. So in 2030, we are going for 84,000 new cancer diagnoses. The prevalence of cancer in the period between 2011 and 2020 is 470,000 people. And if we use the multiplicator 4, it means that there are 3 relatives or family members involved in this, with this patient. We get a burden of cancer of almost 2 million people that are confronted with cancer in our small country. I like to share this testimonial of another patient with cancer. The moment I first suspected my cancer diagnosis, I found myself on a roller coaster. I underwent several tests during a period of terrible uncertainty, after which a diagnosis was made and communicated. A treatment plan was drawn up, and before I realized it, I went from one treatment to the next. I felt abandoned by my body. Others took control of my life. My loved ones and I were faced with fear of the treatment itself, of its side effects, and even fear of not being cured. My treating doctor is best suited to discuss my concerns, but time is always lacking. I wanted to take some action myself to increase my chances of healing, but where could I find a suitable offer? Ideally, I wanted to spend as little extra time in the hospital as possible. And I wanted to hear how others struggle with all these questions and uncertainties. A diagnosis of cancer can have a devastating effect on people's lives. It can provoke a range of emotions, including severe distress, anxiety, depression, helplessness, and uncertainty. And for many, having a serious illness such as cancer, it can trigger an existential crisis, challenging people's perception of themselves, their existence in the world, and their sense of purpose and meaning in life. And this impact goes beyond the person with cancer, to affect families, friends, and caregivers too. In addition to facing the emotional and psychological consequences of a cancer diagnosis, people often need help with accessing information appropriate to their circumstances. They may need advice regarding treatment or managing side effects. They seek details on nutrition, benefits, or making changes that will improve their physical and psychological well-being. And that is where we have to mind the gap. It was already said before, there is a huge difference between evidence-based medicine and patient-centered medicine. The evidence-based medicine is the one I learned at the university all those years. They use the best available scientific evidence for clinical decision-making. And it's the result of the research studies that guide this clinical practice. The aim is that the patient receives the most effective and efficient treatment on the best available evidence. But patient-centered medicine is something different. There, it's the patient's values, preferences, and needs that are at the center of the decision-making process. Because each patient is unique with different experiences, beliefs, and priorities. We have to collaborate with this patient to understand his goal, his preferences, and we have to develop treatment plans that align with what our patient wants. So you see there's a different focus, but they're not mutually exclusive. We need to go for the combination. That is the best approach. That is integrated care. This is the story of Casa Calienta, Coda, and A Touch of Rose, 3 drop-in houses that offer this complementary care to patients and their relatives. So what is this complementary care? It's all the non-medical treatments that are supplementary to the standard medical treatment. I'm a medical doctor, so I really believe in the medical treatments, and this is not the same as an alternative treatment. An alternative treatment is a treatment that comes instead of the classic treatment. Complementary treatment goes supplementary. It goes together with the classic treatment. And what do we offer in these houses? And we do not only offer it, but we co-created it together with the patients and the families according to what they needed. So we offer nutrition courses and workshops which inform and support the patients in making nutritional choices that can modify the risk of cancer recurrence or offset the side effects of the treatment. We offer physical activities such as yoga, recreative walking, fatigue management workshops, courses and group or individual psychological sessions to build the confidence to take exercise again. We offer mindfulness-based stress reduction courses to support patients and their family and friends and to reduce their level of distress. We offer body-oriented therapy such as massage or facial care. And by organizing all these workshops in our houses, we create the opportunity for people to meet others with whom they can identify, either around the kitchen table or in any of the workshops or support groups. To hear personal stories of how others have overcome cancer obstacles can be one of the most powerful means of helping people increase self-efficacy and gain confidence to take on the challenge of cancer. What are those benefits of the complementary therapy? We see reduced side effects and improved quality of life during treatment. We see improved emotional well-being. They help to manage anxiety and depression. We also see an increased treatment adherence because there are fewer side effects, so the treatment outcomes are better and the survival rates are better. This holistic approach is not only addressing physical aspects of cancer, but also emotional, spiritual, and social aspects to help patients feel more supported. They're not alone, never. So we want to empower our patients to regain control of their life and relationships. Our houses offer an environment that can affect well-being. We offer a space that feels warm and supportive, whilst also being stimulating and intriguing. The houses are domestic in scale, with a kitchen and a coffee area to facilitate social interaction and a sense of community. The interior is comfortable and home-like, but also aesthetically sophisticated. It is decorated with fabrics and colors that are totally different than those used in the hospital. Even the coffee cups and the cleaning products are different to create a completely different environment. We welcome people with cancer, their family and friends, at any point in the cancer journey. Diagnosis, treatment, post-treatment, recurrence, end of life, and bereavement. Every week we organize all kinds of workshops or gatherings on which everyone is welcome. Our program is free of charge, with no referral required, and people can access our support whenever they need it. And there we come to the 50 Shades of Rose. Maybe you thought something else was going to be told. It was on purpose, we admit. So in the Netherlands and the United Kingdom, walk-in centers such as ours are brought together under the umbrella of the Ipso homes or the Maggie centers, and they have already proven their added value. In Belgium, there are 27 drop-in houses that run on voluntary commitment, supported by the Foundation Against Cancer and Kom op tegen kanker. They have a bridging function to medical context and cooperate with hospitals and healthcare professionals. They improve the quality of life of patients with cancer and their relatives. But they need structural support by the government to make them an essential part of the integral approach of patients with cancer. Because we believe that every patient with cancer and their environment is entitled to this integral approach, not only in a touch of rose, but in various drop-in houses, which we refer to as 50 Shades of Rose. I thank you for your attention, and the questions will come afterwards.
Thank you very, very much, Anne-Marie, for a fantastic presentation, for so generously sharing your personal story and showing us how you've applied that and really transforming the lives in the community. It's very touching. So with that, colleagues, I would like to introduce you to our next speaker, and that is Claire Bryant. And Claire is from the, and just bear with me here, she is from the Hywel University Health Board in Wales. I will practice, I promise. And Claire will be sharing the work that she's doing in Wales to improve the health and well-being of the community. So Claire, the floor is yours.
Thank you. Thank you very much. So yes, it's Hywel University Health Board, and I'm an advanced nurse practitioner. I'm really grateful to be here today just to share our experience, as so many of us have been during this conference. So Borth is a village, a beautiful village and seaside resort in Ceredigion, Midwest Wales. And for those that haven't been to Wales, come. It's beautiful. It's a lovely place to be and live. The community of Borth and the surrounding area has a high elderly population, as well as a rural farming population who often engage late in statutory services, health and care services. The community is well served with a GP surgery, community pharmacy, community health and care teams, and a number of third sector organisations, and a wonderful community hub run by volunteers and funded by charity. However, there is little coordination between the different organisations in providing individual person-centred support in the community, leading to increased duplication and demand on statutory and healthcare organisation, lengthening waiting times and impacting on the health and well-being of the local population. The recent pandemic has exacerbated this, and this is a story I know that we've heard in most of presentations over the last few days. And it's increased demand on primary care and reduced availability of clinicians to manage complex health and care needs, leading to escalations to secondary care and increased referrals into local authority and social care. This project was established to transform the way that we work together to provide integrated person-centred care in the community and focused in the community. Through enabling the local community teams to deliver effectively, the resilience, health and well-being will be improved for all residents and visitors and families in the locality. So the aims and objectives, looking and reviewing the strengths and the needs across the locality initially, providing anticipatory care to the population, establishing a multi-agency team. And I know for those of you that work within health, we talk about multidisciplinary. I saw a presentation yesterday about transdisciplinary. And interestingly, one of the people that I spoke to in my role said, when you invited me, because originally in the project we called it multidisciplinary, not multi-agency. So this is why we had this conversation. And when you invited me to the multidisciplinary team meeting, I thought, oh my goodness, what's someone done in Borth? Because they're going to be disciplined. And actually, it always sat so uncomfortably with me that we were inviting people to a multidisciplinary team. How are they going to understand? Most people don't understand what that means. And so every time I said it, it felt uncomfortable. And I was like, how can we move the name of what we're doing? And that's why that evolved, and we now are multi-agency. And I don't know whether that's right, and I'm sure in time that will change again, but it feels right to be the multi-agency team as opposed to the multidisciplinary. So the process, and again, we've heard a lot about processes and how everyone's been doing their projects, so I don't want to focus too long on this, but a group was set up in the local area as a kind of consultative group to think about how we can challenge current processes and how we can develop and innovate and transform. And from that, this is our project, the project that I'm here talking to you about today. The idea of what we did evolved. And we were really very fortunate to put in a bid proposal to the Bevan Commission. And for those of you that have seen our poster, there's lots of different projects that are supported by the Bevan Commission. And from that, it enabled us to fund my role, which is the clinical care coordinator, facilitating and leading this project with a real person-centred approach. But most importantly, from primary care, because a lot of the investment in Wales is very much kind of in secondary care, in those teams in secondary care, but it's about starting it in the community and finding out what's important, very much from your presentation, starting in that primary care area and building from that area. So that meant that we could embed from primary care all of the agencies into what we're doing with a real preventative and proactive approach as opposed to a reactive approach, which arguably is the way that our systems are set up. So that needs assessment, we look to see what the actual needs of the population were, because we thought we knew, but it's important to have that evidence behind it. And it's that people are living longer with increased frailty levels, none of which I'm sure surprised any of you, particularly in those rural communities, often in single-person households. The demand on general practice is increasing, and there is a move away now from remote consultations, which were very much prevalent in the pandemic, to more face-to-face consultations. So that need for more time with clinicians in primary care is increasing. During the project, the rate of hospital admissions for patients over 75 remained the same. So there wasn't any change in that need of care during the project, which I think is important when we start looking at the outcomes with regards to length of stay from when we started the project. During the 9 months of the project, we have been able to discuss 104 people in the multi-agency team. Some of those people came in and told us what was important to them, and many didn't come in and tell us what was important to them because they were people who had been admitted into hospital, and it wasn't, we actually spoke on their behalf as opposed to them coming in and telling us what was important to them. So of those 104 people, half were new admissions to hospital, so they'd recently been admitted to hospital. And the other half were groups of people who were in the community still. And for the purpose of the project, to help us evaluate our project, we did focus on specific groups of people, such as frail elderly, palliative care, new referrals into local authorities, so people who had been referred into the social services, social care system, who we wouldn't necessarily know about because their relative might have called up to say that they're worried about their mum because she's not able to have a shower at the moment. So those were the kind of cohorts of people that we focused on. We sought feedback from staff. We sought feedback from the people that we were there, we're there helping and supporting, and the overall impression from people was that it was a good, positive experience, but it was very daunting. So for those of you that work within health and social care systems and attend meetings, it becomes a day-to-day thing, it becomes a normal thing. But for people in the community, when you invite them into a meeting and say, oh, come meet everyone and tell us what's important to them, I don't think I even still appreciate, and it's something I'm constantly reflecting on, how best to, and whether you really can actually really support and prepare people for that feeling when you come into a meeting and have 10 people sitting around a table and then 10 people on a screen, because it's a Teams and in-person meeting. And that can be really intimidating, daunting. And some people don't want to come. And that's okay, because I can be there for them and I can say what it is that they want me to say on their behalf. This word cloud really speaks volumes to me. This is from the staff, the multi-agency representation that attend the meeting, and we've asked for their feedback of their experience of being part of the project. And some key words: communication, patience, multi-agency team, collaboration, beneficial, improved care, patients' needs. You know, really key words that just stick out. And it's what we feel, but it's so important to actually hear that coming back from the people that are part of this different way of working in the community. So the impact. By the employment of a clinical care coordinator, me, in primary care with dedicated time to facilitate the meetings is an essential enabler. And I think the key here is it's about dedicated time to be able to have that person-centred approach and ask what is important to the person. The frail elderly group of people that were identified using the frailty scoring system on our clinical system and being able to invite them in really supported that person-centred approach and kept it very much about that person. Due to small numbers and availability of information, analysis of social services local authority data was limited. However, there's not been an increase in the number of new care packages put in place. Secondary care data has demonstrated a statistically significant reduction in length of stay for Borth surgery. So when comparing data, we have there's been an increase of 40 admissions over the last over the time of the not 40 admissions, sorry. There's been a reduction of 553 bed days, which is significantly a cost saving. So I really want to, I know I've only got 2 minutes left, and the enablers and barriers are nothing new to what you've seen over the last couple of days. So I just want to quickly tell you about Mrs. B before I finish. So Mrs. B is 86, and Mrs. B lives alone with her dog in a bungalow in a rural location. Her family lives 6 hours drive away and support remotely, visiting occasionally. Mrs. B is frail. She has declining memory, cognition, mobility and confidence. Mrs. B's daughter contacted the local social care department concerned that her mother was not managing well at home. As a result of that referral, Mrs. B was brought onto the agenda for our multi-agency team meeting because it was a new referral to social care that none of us would have known about if it hadn't have been for the meetings that we hold every week. As a result of the referral, she was added to the agenda for discussion, and during discussions, we were able to communicate that Mrs. B had been seen in the local primary care surgery, GP surgery, a number of times in the last 3 weeks and treated for a urine infection, chronic leg ulcers, requiring pressure area support and care and regular monitoring. She was now being visited twice weekly by the district nursing team, and the social care representative informed the team that they were in the process of sourcing care twice daily for Mrs. B. It was agreed that we would speak and support Mrs. B again in the next meeting the next week. At the following week's meeting, the district nurses were able to provide an update. Social care were still trying to source carers. Mrs. B had had another fall that week and her confidence was declining. A referral had been made to a safe and steady service for home assessment, and some short-term equipment was provided, but Mrs. B felt she was unable to leave her house anymore and her neighbour was supporting with her dog and her shopping. A week later, at the next meeting, social services were able to confirm that carers were now in place. The district nursing team were continuing to visit regularly, and it was felt that at that time, Mrs. B had all the services wrapped around her that we could provide at that time. Over the next 3 months, Mrs. B continued to deteriorate, with significant issues highlighted as loneliness, isolation, and low mood. The clinical care coordinator visited Mrs. B at home and invited her to come with her family to our meeting and tell us what was important to her, because we'd put the services that we had wrapped around her, but we still weren't providing the support that she needed. A month later, Mrs. B attended our meeting from her home via an iPad with the support of one of our medical students from the surgery, and her granddaughter also attended from her home in the southeast of England, a good 6-7 hours drive away. Mrs. B was able to tell us what her concerns and worries were, and they were focused on her loss of confidence, her declining mobility and her fear of leaving the house. Her loneliness, she additionally felt that loneliness and isolation was significant since her husband had died. She stated that even with the daily support of friends and neighbours, she still felt very isolated. She stated that the most important thing to her was her dog and staying in her home and being able to be there as long as she possibly could. From those discussions, actions were agreed and a shared decision-making process with Mrs. B was made. And a number of actions were made for supporting Mrs. B. And I'm glad to say that 3 months later, at one of our meetings, it was fed back that Mrs. B was continuing to manage at home with the support of the district nurses, the local community care support, and she was also engaging with the local community hub. Mrs. B was having attendance from someone from the local hub to support her with art therapy, gardening and some things around the home. And I'm really pleased to say that now Mrs. B is agreed that she's attending the weekly cafe and crochet class at the local community hub, which is a significant step forward for her. I think Mrs. B's story is a great example of how Joined Up Working has supported a person-centred approach, enabling Mrs. B to stay well at home, utilising community resources and technology to support what really matters to Mrs. B. Thank you very much.
Thank you, Claire, for a fantastic presentation and again for bringing this to life by again speaking to the life of Mrs. B. Colleagues, I'm very pleased that we're now going to move from Wales to Portugal, and we have Diane Breda from the Hospital Arcebispo João Cristomoso, and she's a healthcare manager and chair of the hospital board, and she will address the experience of integrated care in the hospital and speaking to the Portuguese experience. The floor is yours.
Hi, thank you very much. Wow, what a session. I'm quite overwhelmed with everything we've seen here. Thank you all very, very much. I'm talking to you, I'll say the name of the hospital only once, it's Bispo João Crisóstomo, only Nieves understood it, and I'll refer it to hospital from now on, because that's what it is. Where? I'll sit there. I'm too small for this, okay. So we're a normal hospital, we're a public hospital. I tried to make it, we arrived on 2020, and I tried to make it into a community hospital. I'm still on baby steps from your experiences, but we're walking the path. We're the only institution in Portugal which is a participant on the age-friendly health systems from the Institute of Healthcare Improvement. Okay, so this is Cantanhede region, and what I wanted to highlight was the aging index. We have a very, I would say, it's an enormous problem in Portugal with aging, and in the central region of Portugal, which is where we are located, that's even more serious business. And we also have some, Cantanhede region is quite large for us. It's 400 square kilometers, and we do have some scarce public transportation. So what we did, and we still do, we started on 2021, was with focus groups with the community, but also with primary care, and with third sector organizations. We talked to them, and we kind of made ourselves available for what they thought it would be necessary for us to provide them. And they highlighted the exams, that the exams were not available on time and that they had some problems with it. The primary care units in Portugal do not have this diagnostic services, so we started to do it. We have a team. I will not say multidisciplinary team so that they won't get frightened. So there is a radiologist and also some specialist doctors, the lab, the EEG technicians, and now a nurse. So we are involved with, through the municipality or working together with the municipality. We're involved with third sector organizations, which are most of the elders in Portugal when they lose their, mobility and some things and some important functionality features. They go to residential care units, and we also support units with people with disabilities and primary care units. So echo, the services we provide are echographies, it's ECGs, not EEGs, lab tests, referral to medical appointments, and that screening over there, which is too complicated for me to say. But the most important thing is that we, through that was in 2021, and in 2022, we've created a day hospital. And patients are referred to the day hospital whenever they have some kind of, mainly they have multiple conditions and they have chronic disease complications. And the only way that they could go was to an emergency room at a hospital, and we know that's inadequate and that's not where we want these very vulnerable people. So we created the day hospital and the possibility from the doctors to refer to the day hospital. Yes, we have some integrated electronic medical records, but I think what it works is that the colleagues, they call one another and they discuss the patient case and they decide it's the best for that person and specifically, and of course I hope they talk to the person also. So we needed rapid results. The family doctors could refer earlier and reduce waiting times. We do have a problem with waiting times in Portugal. And proximity, this is from the TV, and I thought in bringing it, but then I wouldn't have it translated. But to me, it was beautiful to listen to the patients and to the people that were explaining why this program was very important to them. So we are closer to the community, we have better access, and of course for a reduction of costs, and that's on the perspective of the person that does not have to go to the diagnostic service far away from their homes, and also the carbon footprint. So the patient experience, it's rated as very good. Or good for a lot of people. Of course, it's very convenient to them, and they have several points of care. The numbers of exam requested from external doctors raised a lot, and the coordination with the primary sector units and with these elder residents. But I think the most important is creating the bond of trust between all of this, between GPs and the hospital and with patients. I hope they come to trust us more. We want to expand in the future for other settings, namely home. I would really like, if and when necessary, to go home and to make these exams on the setting on which the person is, and engaging with other relevant stakeholders on a municipality level. I think we still have to deal with these protocols in order to be sure that we refer the patient that really needs this service. That's it. I was very quick.
Thank you so much, Diane, and thank you for, again, talking us through the experience of Portugal and also talking us through the vision, the challenges, as well as the vision. We really appreciate it, and I'm sure there will be a lot of questions for you. With that, colleague, I've not really honored my role of chair. We are running slightly behind, but we still have two wonderful speakers that will join us up here. And I am actually about to take you back to Wales. And our two final speakers for today is Helen Harris, and from the Hywel DDA NHS Trust, and Christopher Richard from the Hywel DDA University Health Board. I'm having trouble saying that word. And they will be co-presenting their work on really optimizing health and well-being for individuals with prostate cancer. So the floor is yours.
Hello, good morning, welcome. We're very privileged to both be here today. So we have a packed service, so we're Prostate Active Care Together team. Myself, I'm Helen Harris, I'm the occupational therapist, and this is my colleague.
Hi, I'm Christopher Richards, I'm the therapy assistant practitioner within the Prostate Active Care Together team in Hywel University Health Board, and we are based in Mid and West Wales.
So we have been working for 18 months with our prostate cancer patients in our trust and optimising health and well-being for our individuals. And the hope is that working with the Bevan Commission that we will be integrating this service into our communities and within primary care. Okay, so just to give you some background really of why prostate cancer. I think my background is in urology as a therapist, and I could see patients coming back constantly to secondary care clinics with issues with side effects of treatments. And I just thought it must be a better way of supporting these patients. And prostate cancer is one of the most prevalent cancers in Hywel, in Wales and in the UK. So that was our reason really for starting with prostate cancer. We would like to scope the service further into other cancer sites at some point, but everybody has to start somewhere. So our patients go through a range of treatment modalities, from being monitored to having radiotherapy, chemotherapy. They go through a range of treatments. And even though the data shows that patients are living longer with prostate cancer, we have found that patients aren't living well, and sometimes their quality of life is poor as well. So the main concerns as a team we have found in the last 18 months in relation to side effects, patients are struggling with fatigue, their general well-being, anxiety, low moods, low exercise tolerance, issues of nutrition, incontinence, sexual health. There's a range of concerns that patients have come to us. So I just thought I'd mention we're a digital service, so we're 100% digital, and we work across dietetics, occupational therapy, and physiotherapy. And this map here just shows really the broad length that we have reached out to patients virtually across Mid and West Wales.
So you can see on this screen here that we've been able to get some really valuable data back from our patients. 96% of users have been able to tell us that from a direct impact from our service, they have felt an improvement within their general life. And we can see from the outcome measures that we have done that 67% of users have had improved outcomes. We can see that people are moving more. We can see that there's an overall improvement to their well-being, and we can see there's improvements in their guidance around nutrition. And we heard earlier from A Touch of Rose the valuable importance of doing that, and we know from the data and the research that we've seen, the earlier we can get to changing those kind of behaviours in a person's diagnosis, the better the outcomes are with their treatments. And that is why we feel our service is really, really important. We want to make these changes. We know medicine is helping people live longer. We want to bring that quality to their lives. Because we're a virtual service, some people with these diagnoses find it very difficult to get out their homes. There are also other factors that come into play where unfortunately some ways of travel are cancelled and people aren't able to make appointments. So being a virtual service makes it a lot easier for people as long as they can get online, as long as they can get onto a computer screen or even a mobile phone tablet, which the majority of people do have these days, then we can see them and we engage with them.
Okay, just to give you sort of a timeline, I suppose, of where we are as a packed service. So we started the service in September 2021, and as I mentioned, our reasons for working with prostate cancer. We're multi-professional, as I've already mentioned, or multi-agency. I just thought I'd put that in, Claire, as well. And I think we were very fortunate that we had time, I think, in secondary care. I think everything is in a rush, and we did have the time to set up the service properly, I think. In December 2021, we held a stakeholder engagement because we really, really wanted to develop a service that was for our patients, not what we felt that the patients needed. So we invited a range of people to that meeting, co-production. We wanted to be integrated, so we had the consultants, we had patients, we had carers, voluntary sectors. We have a West Wales prostate cancer support group as well. They were invited, Prostate Cancer UK and Prostate Cancer Cymru. And that to us was really a good opportunity to see what was valuable for our patients and what was working well, what our trust was doing well in supporting patients with side effects, and what were the challenges and what were the barriers and what we could really support with. So in March 2022, I suppose we went live with our patients. We started accepting referrals. So we started completing only professional assessments. So again, we didn't want patients having to repeat themselves to a dietitian, to an occupational therapist, to a physiotherapist. We wanted one assessment and that we could look at integrated goals from that. Also gave us an opportunity to evaluate the population health need, and again, looking at the barriers and the challenges. We have also devised virtual group, well, as our referral rates got higher, we have arranged and supported a lot of virtual groups. So we've got fatigue management groups up and running, exercise sessions up and running virtually as well, and well-being sessions. But we're finding that these sessions have had such an impact on our patients because we've supported, educated patients, but then they have created their own groups in the communities, and it's been fantastic to see that these patients have gone and created their own support networks as well. So where we're at now, I suppose, from January to March, we took stock of where we were at. We've managed to have a patient experience team to support us with evaluation of, they go out and interview patients to see what they think about our service, what they thought about their interventions, and I suppose how it's improved on their quality of life. Good and bad, we welcome all feedback because we want to improve our service. We've also had support from the waiting list team in Hywel, which has been invaluable to us, I think, as clinicians, because they've been able to support with referrals, and it has freed up our clinical time.
So this is a snapshot of some of the comments that we've received from the people that we've engaged through our service. This is what the patients have reported back to us. And this is the type of area that we really, really want to see. Not only does it reinforce that what we're delivering is right for the patient, but also having this kind of feedback can help us improve our service. We can continue going forward. We can see what's working well, and we can see what isn't working well, and continuously adapt through this model.
Okay, so I just suppose, where are we going next? So the next road in our journey, so we were very fortunate to be accepted on the Bevan Exemplar, and because we were really keen to upscale our project really and scope it wider. So we'll be taking this service and develop and test and evaluate the model with our primary care surgeries. So we did start the project in March this year, so we're very early on. But anticipated, I suppose, benefits for us are that the patients in the community will be able to access information. We want to try and be more proactive in tackling some of these issues rather than hitting secondary care and GP services in crisis mode, because we were finding a lot of these patients are in crisis mode constantly. So we're hoping that if we target them in the community, we will support with that. Also, there's always barriers between primary and secondary care, so we're hoping that this project will allow us to form those bonds and collaboration and build those foundations as well. Obviously, you've got the, we want to enable our patients to support their own health and well-being and improve their quality of life on this journey as well, from diagnosis to palliative at any stage of their cancer journey. So thank you very much. I think we're doing questions at the end, so thank you.
Thank you very much, Helen and Christopher, for a fantastic presentation, and thank you for sharing the experience from Wales. Colleagues, I've not really done justice to being your chair because we are right bang at top of the hour, but I do, of course, want to open up the floor for any questions that there might be for our wonderful panelists. So if I could just take 5 more minutes of your time. Some of you may have to go to another session, so of course we will respect that. But I wonder if there are any questions from the floor. Tatiana, again, don't forget, you can also put your questions in the app. Tatiana, there is a question for you, and there is a very specific question how and to which extent do the community nurse and community social worker work together in practice?
Practice. Everybody is running on their own agenda, but we force them to spend at least, I'm joking, to spend at least half of the day weekly, first to coordinate their cases, to discuss referrals, to follow up the action plans, actual or active cases, and to coordinate care of those that are already in the services that also are coordinated between them.
Thank you, Tatiana. I am looking at our colleagues here, and I wonder if we have any questions. We did ask you, and I have a question. Yes, let me just get a mic for you.
Hello, these have been fantastic presentations, and I'm particularly interested in multidisciplinary working in primary care for older people. And so for the advanced nurse practitioner in Borth, my question for yourselves is, how do you engage primary care physicians who are so stretched in multi-agency working?
So I guess, and I should have probably said it at the beginning, but timing is something I need to practice. The lead for this project is the lead partner for the surgery that I work for. So that has not been an issue for our project. However, I didn't get to the next steps bit of my presentation, and looking now at kind of sharing our experiences and moving out to not just one surgery, but we did actually include another surgery in our project. It has been a challenge, but I think being able to share our story and the experiences and the benefit of what we've been able to achieve, and almost kind of an understanding of how we're delivering it, is the way that we will hopefully get primary care clinicians to, or GPs to, engage in it as it's rolled out. And I'm really pleased to say that the cluster, so we're Ceredigion, and we are just one surgery, well, two surgeries have been part of the project, because halfway through the project another surgery joined us. But I'm really pleased to say that the cluster, the lead GP for the cluster, has very much been enthusiastic about the project and is keen to roll it out by doing kind of a second stage of the project, looking at 3 or 4 more surgeries in the cluster joining it and seeing how that works. Because our model is very small scale, and it's going to, although we've got some key elements of the model that we know are kind of fundamental to the box that we can pass on and say, these are the key things that we think will help you deliver it, it will be a slightly different model for each cluster, and then potentially for each area, because we're very rural, there might be other. So that kind of, I don't know whether I actually answered the question, but I'm hoping that by giving the key ingredients of what we've done, anyone can see that it's worth doing.
Thank you, Claire. I am looking at the colleagues here to see if we have any other questions. So with that, colleagues, I would encourage you to take your questions. There's a lot of networking happening. It is the last day of the conference, but do make the most of the tea and coffee, and do take the opportunity to, again, engage with our wonderful panelists. On that note, I'd like to thank you all for a very, very inspiring session. I think we've all come out feeling optimistic about the future. And again, I'd like to thank the audience for engaging. And again, I wish you a happy last day of the conference. Thank you, colleagues.